Good afternoon, everybody, and welcome to our special Grand Rounds today, co-sponsored by the Department of Radiology and the Royal Gale Cancer Center. Mobile mammography, health equity, and community engagement. It takes a village, and you'll hear the story of how mobile mammography came to be here at Michigan Medicine. Health Equity Month is celebrated each year, this year from March 20th to April 17th. The presentations, events, and panel discussions will help showcase efforts to reduce inequities in healthcare by historically marginalized and underrepresented groups. The theme this year is Building Bridges for Belonging and Inclusion, featuring speakers, hosted presentations and panels, film screenings and book discussions, and community sessions with over 30 events across Michigan Medicine focused on this theme and the intersectionality of healthcare inequities. We have an amazing panel with us today to talk to the different aspects of how mobile mammography came to be and how it is an important strategy in community engagement and reducing healthcare inequities. My name is Alec Hazaruni. I'm the Associate Chief Clinical Officer for Diagnostics in the Michigan Medicine Medical Group, and I'll be your moderator today. Our panel includes Tony Denton, who'll be speaking to us by video, who unfortunately had a conflict to be at an event where Santa Ono is speaking today. But he felt it important that he continue his participation and recorded his video comments ahead of time. Alfreda Rooks, our Director of Community Engagement at Michigan Medicine. Vikas Gulani, the Chair of the Department of Radiology. Larry Ahn from the Royal Gale Cancer Center, who's been very active in preventative services and screening, as well as research through the Royal Gale Cancer Center's efforts. Ebony Parker Featherstone, the Medical Director of the Ypsilanti Health Center, with important roles in health equity, inclusion, and diversity here in her department. Diana Gomez-Hassan, our Vice Chair for Clinical Affairs in the Department of Radiology and our Associate Chief Clinical Officer in the Medical Group for Radiology. Stephanie Patterson, Professor in the Radiology Department and Medical Director of the Mobile Mammography Program. And Lauren Esch, the Director of Clinical Operations with Mammography in her portfolio. There are so many people that have contributed to mobile mammography coming live here at Michigan. Let's begin by some words by Tony Denton, our Senior Vice President and Chief Environmental, Social, and Governance Officer here at Michigan Medicine.
Michigan Medicine is making a really powerful statement about its commitment to community. And through its commitment to community, we want to bring care closer to home. We want to identify communities that have accessibility challenges in order to bring care closer to home earlier in the healthcare journey. We found through the pandemic that there were many areas, communities close to us that have accessibility challenges, have economic barriers, have other impediments that we would call social determinants of health that causes there to be a difference in life longevity based on where one lives, their zip code. During the course of the pandemic, sometime in 2020, through our Anti-Racism Oversight Committee, we identified priorities in how we were going to try to transform how we do what we do in order to improve care for those who live near us, who experience our care when they can have access to it. One specific area was in cancer care. We wanted to address inequities in access that would lead to delayed engagement, delayed visits that could then lead to delayed diagnosis and treatment of cancer. Specifically, breast cancer became the priority for us in considering how we could improve women's health, sustain longer lives by creating and bringing technology closer to home through a mobile mammography coach. So we created a plan, one that led to lots of collaboration across many areas of Michigan medicine, radiology, IT, facilities, communication, community health services, a number of different stakeholders who, in collaborating, created an expectation. And with that, I was able to be executive sponsor to try to provide support to facilitate change, engaging with, in this case, GE Healthcare, to create an opportunity for us to purchase a mobile mammography unit to make it part of our cancer care strategy and to bring it to Ypsilanti and surrounding communities. It was a 1.5 year or so project, so in some ways it was a journey. But upon embarking on the first step of that journey, I can tell you, all of you, that how exciting to be creating an impression where there was not one, to be able to engage with community members, which we did a fair amount, to say, here's what we want to do to improve Michigan medicine presence, with the direct goal of saving lives, of creating opportunities for earlier detection, for earlier diagnosis, for earlier intervention. And then when you think about being able to create that opportunity, especially when people have to rely upon public transportation, and when during an economic drought or a sustained way of living with less dollars available, families are making choices about what they do. And so we can remove that barrier through what we have now done, which is to bring online a mobile mammography coach close to the community that then becomes part of our care model. So I'm just so delighted that we've been able to accomplish that. But it's only one plank of a bigger strategy, because we are in the process of expanding and relocating our Ypsilanti Health Center to a new site at 300 West Michigan Avenue, where we will take the technology of the mammography unit in the coach and put it inside this facility at 300 West Michigan Avenue. That'll give us then an additional opportunity to take that mobile mammography coach and put it elsewhere in other communities of need. So we will be able to continue to build upon our bringing care closer to home strategy, what I also call building bridges to connect communities, such that we are improving our presence, but more importantly, finding a new way to save lives that is transformational. So I can only say I'm just thrilled, and I applaud all those who've been engaged in this process. It's a new step. It's not the last step, because there are so many other things that we are envisioning and imagining as we think about how we can be better partners in care with community across the board. So when I spoke about this being the first plank in the mobile mammography space, there are other strategies that are also underway in parallel. We've expanded the capacity for some select specialty services at the existing Ypsilanti Health Center. The plan that we have for the new Ypsilanti Health Center, it expands and grows specialty care services, diagnostic imaging services, including the mobile mammography being integrated into the facility, which gives us the opportunity to take the mobile coach and put it in other communities. We are currently evaluating the other communities in need so that we can have a readiness plan, so that when we were able to open up the new Ypsilanti Health Center, we will be prepared to then relocate the mobile unit to other communities on a rotational basis. So that certainly expands our investment. It keeps us looking forward to identify who's next as we think about investments. Mobile technologies in general are a part of our thinking. I'm engaging companies right now in discussions about prostate cancer screening, lung cancer screening, mobile health clinics that we can also say can become a second, third, fourth, fifth plank of a strategy of community outreach and bringing care closer to home in fixed sites, in mobile sites that aligns with our other models of care, virtual care, that would be intended to improve access, to create a better, higher sense of belonging and inclusion, as well as a safe quality experience for all those whom we touch. So this is a beginning, not an end. When I think about this particular project, what it means to me personally, I'm engaged in something that's making a difference for others. I measure myself by asking myself the question each day, did I help at least one person? Because I think that's a responsibility for all leaders, to be helping someone get someplace that they couldn't get by themselves, to be a servant leader, to think outside ourselves. So I'm personally pleased when I can hear comments from people in the community. Thanks for making it easier for me to do what I do to get to what I need, and to see smiles, because it's a reflection of people acknowledging that I care, we care, and that's why I'm here, to try to make something easier for others, better for others, and that's an intrinsic satisfaction, I guess. At the same time, I feel like we're catching up. And so I feel personally like it's not just checking a box, it's catching up. And when we talk about inequity being the basis for why we are trying to be actionable and intentional about our investments, it means that we are stepping up. So I feel personally better because we stand in a place where we can make a difference. And when we actually do, to improve our presence, that once again builds those bridges, allows people to make their way, then what better joy can there be knowing that you've allowed somebody to make their way? So that's how I look at it. We have a vision of discovery changing care and care changing lives. I tie that to making investments in areas where there is community need, so that our care can change lives. The mobile mammography coach investment is one example of that. But I think most would agree we have a lot of work to do. We are trying to reverse decades and decades of lack of appropriate access due to societal conditions. We have a lot of work to do to convene the right stakeholders to be partners with us so that we can get farther, faster by working together. There is a lot of excitement about that. As I talk to community leaders, so I would want the audience to know that we are not here to say that we can do this alone. We are embarking upon conversations with government, transportation, housing, food, rescue organizations, to try to create a pathway that really demonstrates our role as an anchor institution, a major provider and employer. So we're making conscious investments with the intent to get a health return. We're making conscious investments in order to try to boost the economic wealth of community so people can make better choices about health matters when they compete with other social conditions. So do know that this is a moment for celebration. We want to continue to launch off of this to continue to do more, because I think our jobs are to do better, be better. find ways to do more in order to achieve more. So thanks.
Thank you so much to Tony Denton for taking the time, and I'd like to also like to thank Scott Redding from the Cancer Center, who's been so helpful for putting this video together with Tony and many of the promotional activities that we've had around mobile mammography to date. So let's make mobile mammography a little more palpable. I know some of you might have had a chance to see the mobile mammography coach when it was here on site doing visits to the center to actually walk through it and see what it was like. But I hope that video gives you a sense of what the coach experience may be like. It is top-rate technology. It is the same high-quality equipment that we have in our fixed mobile mammography facilities, and offers a wonderful patient experience with the staff who were there operating the unit. So I'd like to now ask Alfreda Rooks to say a few words as the Director of Community Health here at Michigan Medicine.
So good afternoon. I know y'all chewing, but you can say good afternoon. Just swallow. Thank you. We need that energy, those of us who are down here in the fishbowl. So as Dr. Kazzaruni said, my name is Alfreda Rooks. I'm the Director of Community Health Services for Michigan Medicine, U of M Health. And what I want to talk to you about today is how we in Community Health Services, as that outreach and engagement arm of Michigan Medicine, U of M Health, work to create and increase health equity in our communities. And when I say communities, that also encompasses our patients, because we do our work in places where our patients reside. So for Community Health Services, our mission is to lead Michigan Medicine in improving access, equity, and health outcomes in the community. And our vision is that anyone who comes into our facility will have access to high quality, equitable, and responsive services that increase comprehensive health as well as well-being. So there are a number of programs within Community Health Services, and the ones that I've outlined here are those programs that we consider to be community-embedded, outward-facing programs, and that they provide services or programs for folks in community. I want to draw your attention to our Program for Multicultural Health, because that is our largest arm that does outreach, working with community-based organizations, churches, building those relationships and the capacity for them to be able to provide health education, health screening to their congregations in the communities where they live and reside. And then our Regional Alliance for Healthy Schools, which are 17 school-based health centers in Washtenaw and Genesee counties, where we have taken care outside in schools, and it's open to any child who is between the ages of 5 and 21, regardless of whether or not you attend that school. And so that's how we make sure that we have access for those schools in those districts where the free or reduced lunch rate are greater than 50%, and they have limited access to medical services as well as transportation. The bolded activity that we do in community is actually the most important one, because it aligns with the mobile mammography unit. We do a community vaccine and health and wellness clinics. In community, we are in Wayne County, Washtenaw County, and Lenawee County, providing services to folks who have difficulty with transportation, and making sure that these activities that we do, as well as immunizations for COVID, immunizations for flu and pneumonia for older adults, but also the health and wellness screens. We screen for A1C for diabetes, we screen for cholesterol, we screen for hypertension. And we see having the mobile mammography unit as an opportunity for us to be able to take additional services to those communities where we are. And so our work really and truly focuses on the social determinants of health. You heard Mr. Denton talk about some of those in his presentation. And so we are really the arm that goes out into community to kind of mitigate what those social determinants may be it transportation, be it food, be it health literacy or understanding. These are the things that we do. And we take those, and we've been doing this for over 20 years on behalf of Michigan Medicine. But what we're going to be doing now is that what the mobile unit allows us to do is to move our services kind of upstream, and that we know that we've already been at that midstream where we have individual impact. But we see the mobile unit as an opportunity to have systemic impact, to talk about policies and what we need to change policies that support women of all ages. Yesterday, MDHHS released a press release that said that they are promoting, and it's important that we provide mammography screening or breast cancer screening for women of all ages, especially because 9% of women under 45 are being diagnosed with breast cancer. That impacts our Black and Brown communities because we know that they are slow to be screened because of access issues, that there are high incidence of death, even though overall white women have the highest incidence of breast cancer. Black women, Black and Brown women have a higher incidence of death as it relates to this. And so being upstream, looking at that right side where we talk about the policies, where we talk about what we need to do to ensure that these services are available to all women, and not just those who have a history or those who have a history of family members with breast cancer. And why do we do this? We do this because it's important to us to create health equity, to create opportunities for everyone that we come in contact with in community to have an opportunity to have increased lifespan and also well-being. And we know that we can do this by taking more of these opportunities in places. We go to Lenawee County to a migrant farm camp. If I were to do a survey, I would probably find out that most of the women who are of childbearing age and who are 40 or over have probably never had any type of breast screening. And so we want to make sure that those opportunities are available for folks. And before I sit down, one of the questions that they wanted to know was, why was this important to me? And so I have to say that, and some people may have heard me say this, but one of my favorite quotes from Martin Luther King Jr. is, life's most persistent and urgent question is, what are you doing for others? And I feel privileged to be in a role that every day my actions, my programs, my services, my conversations answer that question on behalf of our community. So thank you.
Right, so my name is Vikas Kulani, and I'm the chair of radiology here. And I feel a little bit sheepish standing up here because this isn't my work. It's work of a lot of people in our department and outside our department, and I want to acknowledge them first.
Attention, please. The National Weather Service has issued a severe thunderstorm warning for this area until 1:15 p.m. today. Attention, please. The National Weather Service has issued a severe thunderstorm warning until 1:15 p.m. today for the surrounding area. Attention, please. The National Weather Service has issued a severe thunderstorm warning until 1:15 p.m. today for the surrounding area.
Right, so you had plenty of time to read this slide, so I won't read this definition to you, but this is from cms.gov, kind of defining what health equity means from a national perspective. At Michigan Medicine, what does it mean to me? Well, it means that we try to live by these values every day. We should be doing this every day. This should be part of our DNA. And I'm really proud of this department. I think this department tries to do that on a regular basis. But we're not perfect, either in healthcare or at Michigan Medicine. And we've already discussed a little bit about social determinants of health and other problems that exist within our healthcare system. Where we are located physically has implications for who we serve. And this may not be our fault. It's not our fault that where we locate our medical center, and it has great reasons for being where we are in the middle of a great university. But it also means that there are communities that simply cannot be reached because of our location. So a simple question for us is that should where people live have serious consequences, serious effects on their health? And I think all of us would agree that the answer is no. And when this problem exists within a very short drive of our medical center, it's particularly heartbreaking. And you may think of it this way, that if certain patients simply cannot reach our medical center, there is a great divide between the two. And to me, mobile mammography kind of puts our medical center and carries it to our patients. And this is a great opportunity to take ourselves where our physical locations are not. So this could end up helping our patients. And I think in the right circumstances, it could also influence us as a health system. It could help us be more introspective and think about how we deliver care and to whom we're delivering care. So in my opinion, this project is grounded in the best core values of healthcare. And this is why I think this project is so cool. Now, the problem is that the real work actually starts now. We got this thing launched, but now the real work starts, because we have to start by building trust with the community that we're about to go and try to serve. And we have to get people to come there. We have to deliver the highest quality care. We can't have a distinction between the kind of care that people get through this unit and downstream from this. And that brings in the question of diagnostics, of biopsies, of surgeries, of clinical care that are related to starting with a mammography unit. So there's a whole lot of work to be done downstream here. And we have to do it consistently, that we can't drop the ball after getting it started. And finally, we have to deal with the complexities of mobile care. I'm reminded of something that Dr. Rubidoux, one of our breast imagers, said to me in her experience with mobile mammography in the western part of the United States, that you have to deal with winters. You have to think about how a coach might get into an accident. We've already dealt with that a little bit. And so these are issues that we need to think through. So in short, I would say that the mission is definitely not accomplished. This is a starting point for us, but it's a really amazing starting point. So, this whole thing took a village to start, and I'm just going to share with you some experiences from that. I took a trip down email lane last night in building this slide deck, and I found the first, at least saved email exchange on this subject between Carly Davis, who was my admin when I first started, but she got her MPH and started working on this, Prasad Shankar, and Dana Habers. And an interesting thing to note is all three of them have moved on past our department. Dana Habers still within Michigan Medicine. Carly and Prasad are no longer in Michigan Medicine. But they launched this project back in 2019, at least in October, and I think it was probably September. And we started thinking about this. I found a grant submission from 2021 January looking for funding for this project, and it was not funded, which is, to those of you who are in the audience, especially the residents and fellows, negative setbacks are part of every game, and this is no big deal. You just move forward and say, okay, a grant proposal got rejected. And this email from Carly Davis to me: to create a more equitable state for breast imaging screening exams in surrounding communities, the Department of Radiology has partnered with the Ypsilanti Health Center to better understand access needs for our patients in the zip codes 48198 and 48. It got repeated there, but this is an email direct quote from a PowerPoint deck in 2021. So this project has been going on for almost 3.5 years now in our department. My email chains, I tried to look at the names that I have come across during this period, and it's incredible the number of people that have worked on this, both within our department and outside. This is stopping. Both within our department and outside. And it goes to show how many people put in effort and how ridiculous it is that I'm standing up here. Like, this is all the people that did the work. So, I want to go back to this comment. It took a village to start, and I would kind of say that it took a mega city to start this thing, and it took very many people's time, and I want to thank those people deeply. An additional heartfelt thanks really goes to our GE colleagues who really worked with us very carefully and very mindfully to make sure that this project was gonna get across the finish line. And they, Tim O'Shea, I don't know if he's in the audience, but he's our GE rep, and all the way up to the present CEO, Katrine Estramp of GE, who really worked with us to make this affordable. So with this, I want to thank you, and I want to turn it over to the next speaker.
Can people hear me okay? Wonderful. So I'm here representing the University of Michigan Rogel Cancer Center, and we're so happy to have had the opportunity to be part of this wonderful collaboration that you were hearing about. I'm here representing the Cancer Center. We would not have had a chance to be in this position if the Department of Radiology had not reached out to us. It was great that they really found receptive ears from our director, Dr. Eric Ferron, and also Julie Brabs, our chief administrator, managing director of the Cancer Center. What you'll see is that this work fits squarely within the mission of our community outreach and engagement program. We've had the opportunity to work with Alfreda and her teams over the years. Our mission is really to understand and try to reduce cancer disparities across the state of Michigan and to use community-engaged participatory approaches in doing that work. Just an example of some of those, we really are guided by our Community Advisory Board. This is a group of 15 members from diverse backgrounds, faith-based organizations, other community organizations, academic and governmental institutions. I'll just mention as a plug for the audience out there that we have a research advisory subcommittee from our Community Advisory Board. So if you have questions about your research and how to engage with the community, particularly on a cancer-related topic, we would really welcome those conversations. We're committed, following the model of Alfreda and her team, to the idea of community engagement, and we really view that as a bi-directional relationship where we don't feel like we are Michigan Medicine coming into a community to say what should happen, but really starts with listening and sort of co-creating the right solutions for separate communities and communities across the state. One of our strategies is to identify evidence-based interventions and working with communities, understand how to bring those to serve the people living there. We, through the work of Professor Ken Resnikow, do a lot of work with communication training. I think we've learned during the COVID pandemic the importance of communication and building trust in that communication. We have many partnerships with faith-based organizations through a program called Body and Soul, and we have many efforts going on to bring modern quality improvement activities to address cancer screenings across the state. We're doing work with our statewide network of federally qualified health centers to try to address the impact of the pandemic on cancer screening. And this mobile mammography program, as you heard from Tony Denton, will eventually hopefully play a role in that work as well. Our sort of end goal is to really have an impact in our catchment area, which is the state, by regularly providing access to and updates both quantitative and qualitative information about the burdens of cancer and trying to reduce disparities there. All of this work, we've mentioned the team. This is our team. Noel Pingator recently joined as our director for community outreach. Our other team members include Dana Green, our strategic outreach coordinator, Madeline Gonzalez, our health educator, and Patricia Thomas, who is our administrative specialist. And once again, so grateful for the chance to be part of this team. Really fits within the mission of the Cancer Center.
Thank you for that, and good afternoon again, everyone. I'm Ebony Parker Featherstone. faculty member here in our departments of family medicine and obstetrics and gynecology, and I'm also honored to serve as the medical director for the Ypsilanti Health Center. I'm going to talk a little bit today about the Ypsilanti Health Center and the work that we're doing in partnership with Radiology, the Cancer Center, Community Health Services, as we think about bringing mammography services to the patients in that community. First, just a little bit I'll share about the Ypsilanti Health Center for anyone who might be unfamiliar. This is a picture of the front of the clinic. The Ypsilanti Health Center is a primary care facility here in Michigan Medicine. It houses both the departments of family medicine and pediatrics who've been providing primary care in that community for over 2 decades. We're also really excited to offer several specialty care services which have been expanded recently, and some of that you heard through Tony Denton's comments. We also host a variety of other health services. We think about the needs of our patients: nutrition, PharmD services, social work, and other, as you might imagine. What's unique about the Ypsilanti Health Center, one of many unique areas I'll mention, is here is a slide that represents our patient demographics, and I'm going to try to orient you a little bit, and I apologize for the colors. I don't control this data, but what you're looking at, the top row is data specifically for the Ypsilanti Health Center. The middle is Michigan Medicine, and then that bottom row is the Ypsilanti community, so kind of the census data for patients who live in that area. The green bar represents patients who identify as Black or African American. The blue bars are those who identify as white or Caucasian. The smaller bars are harder to read, but yellow are those who identify as other. The darker green are those who identify as American, Indian, or Native American. Also, Asian is identified in the darker blue bar, and then that brighter yellow are those who identify as Hispanic. What you'll see here that's maybe obvious is that the Ypsilanti Health Center actually cares for more patients who identify as African American than does Michigan Medicine as a whole, or even patients who reside in the Ypsilanti community. And so what we knew very early is that the Ypsilanti Health Center is caring for a large number of African American patients, and that provides some specific opportunities as well as some challenges as we think about communities that have been historically marginalized. This slide looks at some of the partner in care screening. The Partners in Care is a questionnaire that Michigan Medicine does with patients that look specifically at social determinants of health. You've heard in several of the talks today already about social determinants of health, and I know this audience is very familiar with them. What I hope you'll notice here is the highest rated areas of need that our patients specifically in Ypsilanti identified. Food insecurity or scarcity is the #1 social determinant of health reported by our patients, but it's followed closely by social isolation and then transportation. Transportation for medical services, but even transportation for non-medical services. And so as we were thinking about opportunities for the Ypsilanti Health Center and the patients in the community that we serve, we knew we had to do so through the lens of understanding those factors that were influencing their care. What's also really important as we think about this is we know those social determinants of health reflect the systemic and structural inequities that exist in our society. This is data from Washtenaw County's United Way, and you might know this already. Ypsilanti is housed in 48197, 48198 zip codes. Maybe you can see that on the screen. It's represented by that blue star on the right side of your screen. That yellow star is zip code 48105, which is where the health center we're currently sitting in resides. What you might know, but if you don't, I'd love to draw your attention to the difference in life expectancy that we know exists based on which zip code, even within Washtenaw County you live in. You can see at the top of the slide that there is a significant difference in life expectancy for Black and Brown members of our community solely based on where they live or even by their race. And so as we think about the Ypsilanti Health Center, we think about the impact of structural and social inequities and barriers and opportunities to address that. And so all of that helped inform our plan around how we might best engage with this community and to think about opportunities to specifically address those structural inequities. That leads us to the Ypsilanti Revitalization Project, which might be the formal title, or maybe that's what I've been calling it, so I apologize if I'm misnomering it here. But it really was an institutional initiative that started years ago, as many of my colleagues have mentioned here, that was looking specifically to respond to the health inequities that we knew existed even in communities that we were serving. Particularly with the COVID pandemic, we saw significant disparities in health outcomes for our Black and Brown patients, many of whom resided in the Ypsilanti community. And so, as an institution, we made a commitment to address those inequities. That included partnership from institutional leaders, our UMMG leadership, as well as our Anti-Racism Oversight Committee, and even our Ypsilanti Health Center leadership. That investment included several factors or several streams of work. One included just a continued commitment to the primary care that was happening there. I mentioned the Ypsilanti Health Center houses family medicine and pediatrics who've been there for over 2 decades. We wanted to continue to support that care and think about opportunities for how we even further expand and provide support for that care. We also looked at opportunities to expand specialty care to address high health burden needs. So we looked at the data for the patients we were caring for at the Ypsilanti Health Center in the community, and what were the highest health burdens? What were the conditions which our patients were diagnosed with most commonly, and where were there opportunities to address some of those gaps in care? Given that, we've had the opportunity over the last year to expand care at the current Ypsilanti Health Center, including the addition of cardiology, dermatology, and expanded pulmonology, endocrinology, and psychiatry care as we think about how to better meet the healthcare needs of our patients. As you've heard from Mr. Denton, we're also planning additional specialty care as we think about the new facility. Some of the other parts of this project included the mobile mammography program, which I'll talk a little bit more about specifically. We've thought about opportunities for improved access to virtual care. We know that issues with internet access, with digital literacy, with even having a device to do virtual care. So many of those set up barriers for our patients to access care, and so we've been intentional in thinking about those strategies. We've had several community listening sessions as we think about how to engage with our community partners and really hear their needs and ensure that our work is in alignment with them. I love that bi-directional comment that I heard, that this is bi-directional work and is not led merely by Michigan Medicine, but in partnership with those that we serve. Our membership in the Healthcare Anchor Network, which I know Alfreda already alluded to, and then the future U of M health facility for the Ypsilanti Health Center, which was already referenced. I also want to mention that a lot of this work has been done in partnership through the Anti-Racism Oversight Committee, for which Alfreda and I are really honored to serve as co-chairs for the Community Work Subcommittee of the Anti-Racism Oversight Committee. So just to acknowledge, as others have, the really broad scope of individuals and groups here at Michigan Medicine who have been a part of this work. Specifically for mobile mammography, this is data that we utilized as we were thinking about this work for the Ypsilanti Health Center in particular. What you'll see is the highest volume radiology exams that were ordered at the Ypsilanti Health Center. And one thing I'll mention that I might not have in the introduction, and I apologize for that, Ypsilanti Health Center, in addition to the care that it provides, the clinical care, we do have some ancillary services, including laboratory services, but the Ypsilanti Health Center as an ambulatory care center does not have on-site imaging. And so that has created a huge challenge as we think about the care for our patients. And so what you're looking at are the exams that have been ordered by physicians at the Ypsilanti Health Center, but we know our patients have to go elsewhere to obtain that imaging, because our current facility does not have on-site imaging. And so on the far left, that percent from IPSI, you're seeing what was performed locally in the community, but many of these imaging opportunities are helping elsewhere just because there was not access in our local facility or community for patients to obtain. That presented a huge opportunity for us to think about how to bring that care to the community, and really is at the core of what this mobile mammography program sought to address. I'd also be remiss if I didn't highlight, and I'm sure others on the panel will speak more to this, and it's already been referenced, the disparity in breast cancer care, specifically for African American women. I'll just highlight that African American women have a high incidence, not the highest. Non-Hispanic white women actually have the highest incidence of breast cancer, but you all are probably very familiar that African American women have the highest mortality from breast cancer, the highest of any group actually. That high risk status is multifactorial. We know some of that is related to access. It's related to social determinants of health. It's related to structural racism and inequity that has limited care. But it also has to do with the tumor biology of those patients, often presenting with more advanced disease and at earlier onset. And so the mobile mammography program really provided an opportunity for us to think about how we address this specifically, knowing that the Ypsilanti Health Center is caring for a higher population of African American patients than anywhere else in our health system. So through mobile mammography at the Ypsilanti Health Center, we have been able to provide on-site breast imaging for our patients, which has really been an exciting enterprise. We launched live in February of this year. Others on the panel will have more information about scans to date or other. I don't know that information, but I can tell you that our patients have received this with excitement to be able to have this in our facility and on the premises. It has improved access because now while they're getting other care, they can get their breast cancer screening done at the same time. It has addressed some of the barriers which I mentioned and have been identified when you think about transportation or other things. We've hopefully helped remove that barrier for our patients because they can get the care in the communities in which they live and are already receiving their primary, or in some cases, their specialty care. It's also led to increased awareness. Just you saw the images of the beautiful coach that we're using. Just having that parked in the lot of our health center several days a week allows patients to be reminded of the importance of breast care. There's information about breast care screening, as well as a QR code and a number to call if you're interested. The beauty of the Ypsilanti Health Center is that it's not just an imaging facility. In fact, we don't have on-site imaging, as I mentioned right now, but it is a primary care clinic. And so folks who are bringing their children in for care, someone who's coming for an urgent health visit has the opportunity to see this coach and be reminded of the access to care that we have in our community. And we're hoping that that also is going to make an impact, with the goal overall to improve early detection, right, and access to breast cancer screening. You've heard about the commitment from our cancer center, our radiology partners, and other, that ultimately this is about identifying breast cancer earlier in patients and providing them improved opportunities for treatment and care. The last thing I'd say is I'd be remiss not to mention all of those who've been a part of this great work. So I just want to acknowledge all the members of the Ypsilanti Health Center leadership team, everyone who's been a part of this mobile mammography project. It is so exciting, the work that we're doing. I think we were all asked to say just a little bit about what it means to us personally. And I'll say, as someone who provides care at the Ypsilanti Health Center, it's been a wonderful thing to be able to see a patient and say, and don't forget at checkout, you can schedule your mammogram and go outside and get it, right? To know that we are closing the gap, when before I'd have to hope that a patient got their imaging elsewhere, either within Michigan Medicine, or often many were choosing to do so elsewhere. But now that they can do that on site where they're receiving other care, we know that the opportunity to have the right patient in the right place, getting the right care, is our goal at Michigan Medicine. It's also consistent with our base strategies as we think about improving access and safety and quality and the patient experience, that I think this mobile unit does so much to do all of that. So with that, I thank you for your attention, and I'll turn it over to the next speaker.
Hi, everyone. I'm Deanna Gomez-Hassan, Vice Chair of Operations and Strategy. I'm going to share with you this inspirational video that really just spoke to me on how this project evolved. Truly a village, as Vikas mentioned. But it's really important to understand how this project really took place. I, too, similar to what Vikas said, heard about it from Carly Davis, who was an administrative assistant in our department, who was also training to be a continuous improvement specialist. She brought the idea forward, and same with Jason Battaglia, who brought a lot of the data and brought the idea that we need to address the inequities in Ypsilanti. So when this idea evolved, at the time, Dana Habers, our CDA, also introduced me to the work and the work that she was participating in the ARAP committee, which we've heard. And she was aware of my interests, my background, and expertise in ambulatory radiology, and felt it was important that we start having these discussions of how we improve our presence in Ypsilanti. Time forward, I started hearing discussions from Ella. In my role as ACCC and Ella's role as ACCO, UMMG took a very strong interest in trying to also address these issues. So I was at the time hearing a lot of parallel discussions, different meetings with different people, and I thought it was really important that we all start talking together. And at the time, since I've been here, I've seen many teams evolve, new players come in with introducing the idea again to new people. It was Marissa when she came on and also started having discussions with Tony Denton and Scott Marquette about what we need to address here. And it was Marissa who said, let's get all these people together. And when I presented that to Ella ran with it. She truly orchestrated all the members of the community. That's how I started to hear about Alfreda and Ebony and Larry and all the work that they were doing and their interests. And I saw the momentum build. And it really required a very structured approach, reintroducing the idea and addressing all the issues that we need to tackle in order to bring on a mobile unit. In my role as vice chair, I have to report to Vikas and keep him informed of everything that's going on. And it's at that time when Vikas said, in all of that planning, we need to make sure that the breast imaging team are the ones who are driving this. So we took it back to Kim Garver at the time. I can't tell you enough how much the input from Stephanie Patterson in her role as DEI, but also in breast imaging, contributed to our understanding of what we needed to address. Also, Becky Hall as a supervisor, and at the time, Karen Keast as a clinical director of operations, also having input in these ideas. And then we have to just highlight, I know there's many, many people that I'm not mentioning here, but it was really important that we take these ideas and really understand and make sure we cover everything so that we are not missing out on gaps and how we do this. So another point that really highlighted in this whole process is when I was at RSNA, I was with Karen Keast and Loisberg. And Loisberg was instrumental as well because we started actually looking at units themselves. We started touring the units and seeing what is it like to actually be in a mobile unit, and brought that information back. To cross the finish line at this point, everybody has been involved now, everybody excited about this project, but the key players were Loisberg, Lauren Esch as our clinical director of operations now, all the IT people, and including Mohammed Bali and Ken Buckwalter, and because in our discussions with GE, who really saw this through to the finish line. So in summary, it's my role. I got to hear, I've been very privileged in my role to hear this project from many different angles. I feel I contributed a bit to being the glue and bringing the groups together. Seeing Ella drive this forward was very, very impressive, and I'm thankful to her for being a part of that. And really, it's really important to understand that the idea, where it came from an administrative assistant, to take this all the way forward with all the people involved and to try to help get all the stakeholders involved to see this through. It's really the most amazing thing, and I've been very grateful to be a part of it. So, thank you. Did the video not play?
Okay.
Oh, it's just, oh, I thought it was playing. Well, you guys are supposed to be looking at that and not me. But really, it's just a project, seeing it in evolution, so I must have not pressed the button very well. I had made some blue scaffolding too. Thank you.
Okay, all right. Good afternoon, everyone. I'm Stephanie Patterson. I'm one of the breast imagers here at Michigan Medicine. I was asked by Ella to participate in this panel as my role as medical director of the mobile mammography unit. That's kind of a fancy term for really what I am as the lead physician for this unit. We our whole division, all of us actually participate in being lead physicians for our different sites. Namely, that means I'm responsible for a lot of the quality control and quality assurance things that go on with the unit, primarily for the ACR. So I work very closely with our manager, our lead techs and so forth, making sure the image quality is where it should be and making sure access is optimized, if you will. So one of the questions that I was asked to answer was describing my perspective of our breast screening program, bringing mobile mammography to the Ypsilanti Health Clinic. So just a little background on me. It's really, I was kind of brought on into this back in June of 2020 when I was the DEI lead for radiology. And so I kind of look at this through the lens of DEI and in terms of improvement and equitable access and inclusion for everybody who needs this this vital screening modality. Just a little aside, I'm glad Carly Davis is being put forth because she really did a lot of this work in her role as the continuous improvement person. She, just kind of an aside, one of my colleagues, Dr. Carol McLaughlin, actually in June of 2020, actually talking about going down emails and things, I actually found these original emails chained, but she emailed me and Dr. Annette Joe and Marilyn Rubidoux and kind of said, you know, I sat in on a urology grand rounds and they were talking about how there's really no imaging services at the Ypsilanti Health Clinic. And she kind of said, you know, why don't we have mobile mammography? Has anybody thought of that? And I said, well, funny you should say that. I was thinking of this exact same thing. Because at the time, if you remember, that was a very tumultuous time. It was around George Floyd. You know, the United States in general was just in a lot of upheaval. It was the middle of the pandemic. So we were seeing a lot of these social determinants of health kind of come to play. Especially in those zip code areas around Ypsilanti, where we're seeing, you know, folks getting really ill from COVID, and just kind of highlighted the inequities, the health inequities in that population. So I think as Tony Denton said, the institution, you know, was kind of looking inward and saying, you know, we really need to serve the communities that, you know, really truly serve the communities that we represent here. And so the discussion with Carly, you know, she brought us in, she's like, I've actually been looking at this. She gave us the data. She'd already pulled, she'd done a lot of work and discussion with the Ypsilanti Health Clinic. And she got to work and talk to other stakeholders, the Rogel Cancer Center, Cancer Advisory Committee, and so forth. So she really deserves a lot of credit with really bringing this forward. And I'm kind of along for the ride, if you will. I mean, my interest has always been in breast cancer detection and breast health in African-American women. I've done this, have been involved with this since I was a fellow here, so decades ago. And you know, the data has just begun, you know, we just still keep getting this data where the mortality rates are so, as you saw there, it was like 40% for African-American women, is 40% higher than for white women. And that's just not acceptable. So we really needed to really make sure that we have that access available for these women. And so that's really my role in this as the kind of the direct day-to-day operations. Some of the challenges that we're starting to see and that we have seen, our division actually has had some experience with mobile mammography with the Indian Health Service in South Dakota through Marilyn Rubidoux. And so we do know there's some issues, there can be some issues. it is a vehicle, so there can be vehicular problems, and so we've kind of had that issue. They can be in an accident and things like that. So we're having that kind of thing you have to be aware of. Weather is going to be a big determination because, again, if it's a vehicle, if there's a snowstorm, it's going to be hard for that coach to go from one place to another. So you have to be kind of aware that, you may have to reschedule people at a moment's notice and things like that. Also, the weather can do some things with, I think, electronic transmission. I think that was a bigger problem perhaps because we were getting things from South Dakota. I don't think this is going to be that much of a problem, at least I don't think so, with just transferring things from our coach to our center here. Right now, we're kind of seeing that a lot of our spots are open. They aren't being filled right away. And I think a lot of it is getting women. I think there's a perception out there that perhaps the equipment that's in the mobile unit isn't as good as what's in the brick and mortar sites. It's the exact same equipment. It's state of the art. It's our digital breast tomosynthesis unit. So it's the same. It's kind of getting people aware that it's not something less than because it's in a mobile unit. So we're working on ways to.
Attention, please. The National Weather Service has canceled the severe thunderstorm warning for the surrounding area. Attention, please. The National Weather Service has canceled the severe thunderstorm warning for the surrounding area. Attention, please. The National Weather Service has canceled the severe thunderstorm warning for the surrounding area.
So trying to fill those spots, we're actively working on that. So I know they're working on getting people to, I think our communications experts are working on ways to hype it up a little bit more and to make more awareness, more people aware of that this is out there. Particular potential challenges, other challenges that we foresee, since this is a screening unit, so we aren't doing diagnostic cases there. There's no ultrasound there. So women are still going to have to come to one of our on-site places, either East Ann Arbor or the Cancer Center, to have, if they get called back from their screening, to have additional imaging done, or if they need ultrasounds and so forth. So it's strictly a screening site. It's not a place where they can get diagnostics done, and we aren't doing biopsies there and so forth. So those are challenges that we're going to be actively working on and seeing how that works. But that's my role in a nutshell for the medical director of the mammography unit.
Good afternoon, everyone. My name is Lauren Esch. I am the Director of Clinical Operations here in Radiology. I'm one of us. And one of the areas that I oversee is breast imaging. I am keeping it casual today with no slides. So yeah, here we go. So in my role, I started here in July of 2022 as the director. And on the second day on the job, I was informed of this project. And it has been a top priority for me. Not a top priority, it's been the top priority for me since then. And it continues to be even after we've gone live with this program. So operationally, a mobile unit from the basic standpoint operates very similarly as a fixed unit. A patient schedules their screening mammogram. They arrive for their appointment, they check in, they change in the dressing room, they get their mammogram, they leave. They change, they check out, they leave. So from a basic standpoint, it's exactly the same. The coach itself is pretty nice. The video does not do it justice. Before we went live, I used one of those dressing rooms as my office for the day. It's quite spacious, it's comfortable. So overall, the unit itself is very nice. Dr. Patterson here touched base on the scanning equipment itself. Is the same scanning equipment that we would purchase or we could purchase for future renovations as we look at some of our outdated rooms. So it's GE Pristina with 3D imaging. So it's our standard of care here at Michigan Medicine. The major difference, which I think is pretty obvious at this point, is that this site is on wheels. So operationally, from my standpoint, there are challenges with that. We've partnered with Ypsilanti Health Center, but that's just the start. As Vikas had stated, this is a journey, and this isn't like a fixed site where you go live and hooray, we're done. We can focus on something else. The focus stays with us because Ypsilanti is not the only community here in Michigan that needs our help. So from the go live standpoint, now we're looking at, okay, who else can we serve? How often do we visit other communities? How do we send those images? That's a huge topic. That was one of our first challenges that we saw with this mobile unit is how do we send images? Because often in underserved communities, we can't rely on cellular data. They're not on a Michigan Medicine network. So what are we supposed to do? How do we get the images off of our scanner and onto Michigan Medicine software? Another challenge is who's driving this bus. For a while, it was me, which was terrifying. So, which is a huge joke in our department. So we had to find drivers. And of course, as Dr. Patterson mentioned, weather is not even getting the bus from point A to point B, but then the stairs are icy. How are we getting patients into the unit? Is salt helping? We're taking ice scrapers and scraping metal stairs. Michigan roads are not perfect. So how do we secure this equipment? There's a lot more to it than a fixed unit. Those are small examples in a very grand scheme program. So ultimately, now we've been at Ypsilanti Health Center for 3 days a week, and eventually Ypsilanti Health Center is going to become a fixed location. So what we are looking at strategically is who else do we serve? How do we prioritize? How can we partner with the state health department? How can we help patients who cannot afford care? Because it's not just about having the access, it's can they afford it? What programs are out there? Because not everybody has insurance, especially in communities such as Ypsilanti Health Center or Ypsilanti or Flint or Jackson or Detroit. So how do we still serve those patients and provide them the access that they deserve? Before we went live with this mobile mammography unit, we offered a couple open houses, one being at our institution here at Michigan Medicine, and then one being at Ypsilanti Health Center. I want to talk a little bit more about the open house at Ypsilanti Health Center because I think it's very important. So Dr. Parker Featherstone did a really good job at showing the data that supports how Ypsilanti Health Center and their patient population is very unique. I saw it in a different perspective that I would like to share today. So formerly, I was an X-ray tech for this department. I think everybody in this room can say, yes, we care about patients, that's why we are here. Ypsilanti Health Center takes that standard and quantifies it by like 1 million. And I didn't see it. I didn't feel the realness of this program or the importance of it or the value of it until that open house. And when we were there and we had offered, I think we were only there 3 hours, and staff were able to come, tour the bus, get some information. We had flyers, we had cookies. It's a very positive experience. But gosh, the emotion from the staff and the excitement, and you could just see how passionate they were about this and how much they valued it. We had patients that toured the bus, and we had a patient that made us fire up that computer and schedule her immediately. She was scheduled on the first day of Go Live. So people were excited. And I think at that point, it really felt real to me, like, wow, we have a neighboring community who hasn't had access to care. And what are we going to do moving forward to ensure the rest of our neighboring communities, and even not even our neighboring communities, but communities throughout Michigan, how are we going to ensure that they have this same access to care? So that's where we're at right now. Future challenges, of course, still sending the images, especially as we drive to northern Michigan or we drive wherever we decide to go, and how do we prioritize those communities? But ultimately, that feeling that I felt with the Ypsilanti Health Center at that open house, that's my drive for this project. That's my motivation. And I think that's, it's just that palpable feeling of importance of why this is so critical. Thank you.
So I want to thank you all for sticking with us for Grand Rounds today, this Health Equity Grand Rounds. It's a really important topic. It's important from soup to nuts across the institution. You've seen not only kind of data and structure and reasons, but I think the presenters today have done a really fantastic job of making it palpable and real to the patients and the community. A group of us recently went up to the Flint Hamilton network, where the medical director is a Maize and Blue, Go Blue physician, Dr. Michael Giacalone. And they are also interested in bringing the Michigan Medicine mobile mammography coach to their federally qualified health center. They have a number of other services already at the facility that come from Michigan Medicine, such as some of our specialty services, OB-GYN and urology. And we could be extending our services to a place where we're kind of already have a footprint. And they also have a need at a distance from Ann Arbor, which, as you so nicely, eloquently talked about, Stephanie and Lauren, is the physical structure of bringing a service and operations to different communities are all things that the team has impressively worked through, one after the other. Some you can hear about ahead of time, and some you don't really understand until now. You're in the moment and you're delivering that care in a mobile setting. We have just a couple minutes for questions, if there's any for the audience. We tried to set this up in kind of a conversational style, if anybody has a question for the panel. All right, hearing none, I would like to really thank the mega city, as Vikas put it, the mega city that it's taken to bring the mobile mammography program to fruition. So many people in and outside of radiology, across Michigan Medicine, across our many organization, and all the way up to Tony Denton, who saw the importance of this project and made sure that it became a focused project so that we could deliver in bringing services to communities in need. So thank you very much to our wonderful panel today and to all the myriad numbers of people who made this possible. Thank you so much.
Can we give a thank you for Ella for helping?
Thanks, Larry. All right, have a wonderful day.